We are still the only 4 people. Okay, attendees. Okay, I can see the people that are on. All right. So, good evening, everyone. I would like to welcome you to. So the other co-host, please mute. I'm going to first. You mute yourself so that I can talk to everyone else for now. Okay. So, good evening, everyone. I'd like to welcome you to our second CME of this calendar year. It's going to be on acute pain management for hip and knee arthroplasties. Post-operative pain is common in such big surgeries, and it's one of the major contributors to patient dissatisfaction following surgery. So as anesthesiologists, our scope of practice has been increasing, and right now includes also providing acute pain management in the immediate post-operative period. So today's talk is going to be about techniques, different techniques you can use to prevent post-operative pain among these patients who have just had surgery. We have quite a number of attendees right now. There are about 15. We are going to start off with the sponsor for today's talk. So the sponsor for today's talk is B. Brown. B. Brown is a recognized manufacturer of various anesthetic gadgets and drugs. But today we are going to have a talk mostly about peripheral nerve block things that we can use that are part of their portfolio. So we are going to have a talk from the country representative, that is David Senkungu. You can call him for any of the products he's going to mention today. So he's going to give us a brief talk of 15 minutes to tell us what exactly they have. So David, you're welcome to talk. You can unmute yourself.
Okay, thank you, Dr. Andrew. Welcome everyone for this CME on acute pain management for knee and hip arthroplasty. And basically, I'm just going to give you the perspective for B. Brown in a pain therapy approach. As Dr. Andrew has told you, B. Brown is a medical technology company, and one of our major focus is in regional anesthesia and pain therapy. So most of my focus is going to be on our nerve blocker portfolio, the peripheral nerve block portfolio, and also our elastomeric pump offering. So excuse me. Okay. So our focus lies on complete process of from prescription till discharge, and B. Brown can provide high quality products for all process steps in this. And our main focus is basically in orthopedics, oncology, and obstetrics. If you look at the process, we basically look at prescription, we look at patient access, we look at preparation, we look at application and discharge. So when we come to prescription, you'll see that we offer a good portfolio of medications. Here we have systemic anesthetic hypnotics, opioid analgesics, muscle relaxants, and also we have sedatives and opioid antagonists and sedative antagonists. We also have ropivacaine, which is a local anesthetic used usually in regional anesthesia for acute pain management, and lidocaine, which is a widely used local anesthetic. For patient access, if you also provide devices, we have the Introcan Safety and Introcan Safety with Introcan Safety 3 and Vasofix Safety. Now, these are basically for peripheral venous access, and these offer passive safety mechanism. Basically, as you draw the needle, it usually has a covering which protects you from needle stick injuries. For central venous access, we usually have the Atrophies family. Quite a number of you doctors have been using it, and CoverFix. Then we have spinal anesthesia. We do offer the PenCan. That's our pencil point spinal needles. We do have SpinalCan. That's our Quinke spinal needles. And then we have Ultracam. Currently, we don't offer that on the market locally, but it's something we might look to introduce in the near future. Then for epidural, we have our epidural kits with our Perican needle. That's our toy needle. Then for peripheral nerve blocks, we do offer you the Contiplex and Stimiplex family for both continuous and single shot nerve block needles. And I believe a few of you have used this. Both Dr. Andrew has used the Contiplex, and we've also had some of you using the Stimulx Ultra. When it comes to preparation, we have quite a number of admixture tools we avail for you. We have filters, we have solutions, we have admixture devices, quite a number of them, as you might see in this range. With the time, actually, I'll be introducing quite a number of these, which will be essential in your work. So as I continue visiting you, I'll be alerting you of the new products I'll be bringing in the market. But currently, a number of these are not yet available on our market. But within the East African market, at least quite a number of these have been introduced, and I hope to do so here too. When it comes to application, you've used some of our automated syringe pumps, the space pump in the Heart Institute. I believe Mulago has some in the ICU Women's Hospital. We have elastomeric pumps, we have epidural kits, and then we have the catheters, like for the epidural catheters, among other products. Then for reducing risk of misconnections in regional anesthesia, we have the NR Fit. So some of the benefits, it's a dedicated connectors intended to help reduce the risk of misconnections, and they are 20% smaller in diameter. And then they have a yellow coding where feasible to allow safer identification of regional anesthesia devices. So this is a product, I believe, if it's something we feel or you feel that you will need to have, it's a product we can include in our portfolio. And you'll see we have it in the area of patient access, preparation, and application. Then for discharge, we'll offer you our elastomeric pumps, and you know that hospitals can reduce their patient treatment costs by up to 60% when shifting the infusion therapy to home care. So in terms of early prostate post-operative mobilization, which decisively impacts on patient outcome and discharge from hospital, there are three effective ways to continue post-operative pain management. So when applying continuous peripheral nerve blocks, wound infusion catheters, or portable single-use elastomeric pumps, it's possible to administer the necessary anesthetics, even in home care settings. So we'll discuss about our elastomeric pump offering when we come to that part. So now, if we look at our portfolio of our peripheral nerve blocks, you'll find that for the nerve stimulation alone, we have the nerve stimulator, that is Stimulx HNS12. That's our nerve stimulator. And we do offer a range of needles for single shot, that is Stimulx A and Stimulx D in various sizes, length, and bevel types. Then we do have also for continuous drug administration, that's the Contiplex range. So we have Contiplex D and Contiplex S. This comes both with the facet bevel and the TWI needle type. Then we also have the dual guidance. Now here you're basically combining both nerve stimulation and ultrasound guidance in doing your block. And in this we have the Stimulx Ultra and Stimulx D+, and also we have the Contiplex needles in relation to that. Then we have the ultrasound guided needles only And here, actually, we have Xperia. I don't know if any of you have heard of this system. It's a product we developed with Philips. It's an ultrasound system, basically, which has needle point technology. And this helps you in actually improving on your precision of the blocks you make. It's a product, I think, that was released about 3 years back, and hopefully we should have it in our market soon as I engage on the product. So in this range, we have the Ultraplex, Quantiplex S Ultra, and Quantiplex 2E Ultra needles. So if we look at the Stimulx HNS12, we have features. Basically, it has a large LCD screen with advanced ergonomics for a good grip and large display. It has alarm screens and acoustic signals for relevant in case of signals of relevant deviations. We have a diagnostic digital ratchet control knob for precise and tactile current adjustment. Then we have the instant key settings to allow quick switching between stimulus current and impulse duration, and is easy to navigate menu for entering values and advanced settings. And one of the things I would like to talk about when it comes to one nerve stimulator is the Sense. So we have a software which is called Sense. The new software version of Stimulx NH12 offers a new function called Sense. That is called Sequential Electrical Nerve Stimulation. So Sense technique utilizes a series of 3 electrical pulses of varying pulse duration at any given time. The 2 pulses of exactly 0.1 millisecond are sequenced with a pulse of longer duration of 0.3 milliseconds. And how does it work? As you advance the needle, Sense generates 2 short and 1 long pulse. The longer pulse elicits a motor response even when the needle is far from or not around, aimed at directly at the nerve. As a result, you will see 1 twitch every second. As the needle advances closer, the smaller pulses also reach the nerve, which enables you to see 3 twitches every second. Reducing the current of the stimulator during the needle decreases the length of the longer pulse. The shorter pulse durations are more effective in helping to pinpoint the final position of the needle tip. If you lose the twitch altogether, the longer pulse duration can help find it again, even without increasing the current. So basically, that's a brief on this sensor software technology we introduced in the Stimulx NHS12 nerve stimulator. And coming back to Xperia, as I told you, this is a product we introduced about 3 years back, and it's a point of care ultrasound system with special focus on regional anesthesia and vascular procedures. So basically, it has the on-vision needle pointer visualization technology, which will help you pinpoint the needle point when you're doing your ultrasound guided blocks. So this is something we developed in conjunction with Philips. If you look at our portfolio of we do provide quite a number of them. And as you see, we have those with facet bevels, mainly 15 degrees and 30 degrees. And Stimulx A, basically 30 degrees insulation, a full tip insulation. And that is basically for nerve stimulation. Then we have Stimulx D. And this one you will find that we have both 15 degrees and 30 degrees facet bevel needles and pinpoint insulation. And this is also for just nerve stimulation. When we look at Stimulx Ultra, now this one we have facet bevel 30 degrees, full tip insulation. Then it's both for ultrasound. Yeah, that is Stimulx Ultra. Whenever you see Ultra, then it means it's involved in ultrasound, for ultrasound and nerve stimulation. Then we look at Ultraplex. This is mainly for what? Ultrasound guided. And it has a facet bevel 30 degrees and a full tip insulation. Then we have the Stimulx D+. We have a needle of 15 degrees and 30 degrees, pinpoint insulation, and both ultrasound and stimulation. Now on the market currently, for those who have used the needles, we have the Stimulx Ultra 360. Now, this is for single short nerve blocks under both the nerve stimulation and ultrasound. And then it has the safety code with high visibility of the X pattern reflectors. As you see the needle, you have those X patterns basically. And so those are all around the needle, and these offer a highly reflective surface against the the ultrasound wave. So it's a highly echogenic needle, and it's a 30 degrees Stimulx facet B4. Then it also has a 50 centimeter long DEHP free injection tubing. So the length we offer are 35, 50, 80, 100, and 150 centimeters. I think on the market currently we are offering 100 centimeters. And then the gauges we have are 20 and 22. Ours, they should be 22 gauges, the one we're offering on the market. Then we come to the continuous. These are the different types of needles, excuse me, on that we are offering. We have Quantiplex E, and if you see the different variants, we have the 15 B4 facet needle, the 30. Let me hope my is still on. Yeah. Yeah, then we have the Quantiplex S, and that is a 20 degrees facet B4 needle for both nerve stimulation, for nerve stimulation, and we have used the standard catheter. Then we have the Quantiplex S Ultra. Now this is used for both nerve stimulation and ultrasound, and here we use the Quantiplex Ultra catheters, and these are highly echogenic needles, so they have high visibility under ultrasound. And then we have the Quantiplex TUI. Now this is basically has the TUI needle, and then it's both for nerve stimulation. It's basically for nerve stimulation, and we use the standard catheters. Then we have the Quantiplex TUI Ultra. Now this is both for nerve stimulation and ultrasound guided, and we use the Quantiplex Ultra. Yeah, Quantiplex Ultra catheters. Then we do have the Quantiplex C. Now this one is unique. Most of the others which I've been mentioning, it's you basically thread the catheter through the through the guide needle. But when it comes to Quantiplex C, it has the catheter over the needle. So as you're doing your block, your catheter is already on the over the needle. So once your block is done, you just withdraw the needle. Yeah. So that is the Quantiplex C for continuous peripheral nerve block, and it offers you for both nerve stimulation and ultrasound. We offer it with a 25 gauge, 190 millimeter insulated stimulation cannula, and the catheter is 19 gauge and 188 millimeter Quantiplex catheter. So this is the catheter over cannula technique, because the catheter is already on the on the cannula. So as you go in to do your block, once you're done with the block, the initial block, then you remove and then you continue with with your catheter for the continuous block. So after the blocks, what happens? So usually you find you have to discharge your patients, or you need to continue giving them medication. What we offer you then there is the Easy Pump 2 from B Brown. And if we look at our portfolio, we have currently 2 offerings, but the main one we are focusing on this market is the Easy Pump 2 for both short and long-term infusion therapy. Now we have Easy Pump Pain, but that is something that at a later time I'll discuss when it's available. But currently what we look at is the short-term and long-term Easy Pump. Now you know that when you look at elastomeric infusion systems, one of the benefits, if you look at continuous delivery of medication for different kinds of therapies, ideal for ambulatory patients or patients receiving home care. It offers preset parameters, so fixed filling volumes and flow rates. And the other thing is independent from external power supply. So it's not like the automated infusions where you need a power supply and all that. No, this one you will not need that. So if we look at the elastomeric pumps we offer, so these are the different features of the pumps. We have a closing port that facilitates proper closing of the liver lock filling port. We have a comfort cap for safe protection of the filling port. Then we have the filling port, which allows effortless filling process with any Luer-Lock filling device. We have the elastomeric membrane. So that's the inner membrane of the elastomeric membrane made of silicone. Is the fluid reservoir containing the medication and works as the pressure source. Then we have the outer shell, which is a resistant PVC material, which protects the inner elastomeric membrane against physical influences that may occur externally. We have the clamp, basically that is to start or stop the infusion. Then we have the tubing, which is kink resistant. Then we have a filter, which is both particulate and air filter. It's about 1.2 microfilter for both air and particulate filter. Then we have the flow restrictor. This regulates the flow, which ensures constant and accurate delivery of the medication. So we have the patient connector for safe and comfortable access, and then the closing con. So for proper closing of the patient connection. If we look at the operational principle of our elastomeric pumps, the elastomeric membrane functions as the fluid reservoir and the pressure source. The fluid reservoir of the pump increases while filling the elastomeric membrane. Yeah. The medication is delivered to the patient by positive pressure, which is generated by the strain energy of the elastomeric membrane. The flow rate is determined by the combination of this pressure and the flow restrictor. So that's basically the working principle of this elastomeric pump. And if we look at our portfolio, we offer you a portfolio of about 30 different versions. We have the long-term elastomeric pumps and the short-term. If you look at the two, short-term is basically you're looking at infusing between 30 to 4 hours, and long-term you're looking to infuse between 12 hours to 11 days. So this is our portfolio offering, basically, as you may see it. If there is any interest in that, I can offer more information. And we also do offer it, have more information in our catalogs, and some of the brochures I've shared previously. So if you look at the key applications and indications, with the short term, we're looking at in anti-infective therapy, approximately 80%, and that is in cystic fibrosis, Lyme disease, osteoid, and also in antiviral therapy, approximately 15%, that is after transplantation treatment. Then for the long term, we have in chemotherapy, used a lot in the Cancer Institute or Cancer Ward, about 80%. I'm still trying to engage the guys at Cancer Institute, but I believe they also have a few they have used. Pain management, approximately 10%. And in other indications, we have for heart failure, sickle cell anemia, anti-infective, and post-operative pain treatment. So thank you very much. Hopefully I was not too fast. I had to cut it down because I knew I had little time, because there were more slides I removed. But in case of any questions, I'm open to respond to them at a later time.
All right. Thank you, David.
Welcome.
So that was, hello, David?
Yes, please.
Yes, thank you for your presentation. Huh?
You're welcome.
So that was the country representative for B. Brown in Uganda. He is the one that's going to help us get more funding for various conferences and workshops that are being scheduled. So on this system, we are using the webinar system. That means you cannot, your videos are not on live. You're also muted. So we shall use the Q&A section for questions. Chat section is for any other business. Then you can raise your hand if you have a question as well. All this we shall do at the end of the talk. That's when we shall answer all the questions. But since we have one question only for now, to you, David.
Yes,
so
please.
The question is from someone who is interested in getting ropivacaine. They're wondering where they can get ropivacaine.
Okay, currently we are in a process of registration of some of our pharma range, and I'll be informing you in due course. We have quite a number of products we are looking to introduce, and some of these will be some of the products we'll consider, but I'll alert you once the time comes to introduce that particular product, but it's not yet available on the market, but we are working on some registrations with National Drug Authority.
Okay.
Yeah.
So, all right, thank you. That's the only question I have for now.
Okay.
So Dr. Charles Kojjo, you could share
Thank
your
you.
screen. So David, I'll talk to you later with more questions.
Okay.
All right.
Good evening, ladies and gentlemen.
So Kojjo Charles, hold
Yes.
on. Yes. So today's talk is about acute pain management for hip and knee arthroplasty. The presenter is Dr. Charles Kojjo. I am the moderator, Andrew Emyedu. I'm a resident in anesthesia and critical care. Dr. Charles Kojjo has a master's degree in anesthesia and critical care. He has extra training in regional anesthesia and acute pain. He also has special interest in chronic pain management and research and public health as well. He is the consultant anesthesiologist at CoRSU Hospital, which is a center of excellence in East Africa for orthopedic and plastic surgery. They do a number of hip and knee arthroplasties, and he is the best person to present this talk. So like I said earlier, post-operative pain is one of the major contributors to patient dissatisfaction following surgery. And as anesthesia providers, our role has extended out of the OR. So we are now expected to provide acute pain management in the immediate post-operative period. So we are here to learn from an expert on how we can better manage our patients' pain for the immediate post-operative period following hip and knee arthroplasties. So Charles, you can now start the talk.
Thank you, Andrew. Good evening, everyone. For purposes of clarity, I'm just going to request that I turn off my video. My internet may not be able to support the video recording. Yes. Why acute pain management for hip and knee arthroplasty? I mean, yeah, we have the aging population. We have increasing non-communicable diseases. And with this, we are seeing an increasing number of patients that are coming in for this. And they are considered to be one of the most painful orthopedic procedures. So as a matter of an introduction, yes, in most of these developed countries, of course, England and USA, they do a number of surgeries, knees and hips, about 150 for knee, and then about 700 for knees. That's in the United States. And one of the most common indications is osteoarthritis, yeah, because of the aging population and the increasing weight, and of course, a vascular necrosis for total hip arthroplasty, and that's one of the major indications, even within the African continent. And of course, the patients that have undergone these arthroplasties, usually they have improved quality of life, and even the functional status kind of improves. In fact, when they have one surgery on one side, they will come for the other, they will crave for the second surgery, for the other hip to be replaced or for the other knee to be worked on. So they really have improved quality of life. They go back to their normal duties. And yes, so in the African continent, let's say sub-Saharan Africa, we are not doing a number of these, probably because of our economies, and of course, most of our population, people are not able to meet the costs for this, range of about 6,000 to 9,000 US dollars. So the overall rate is very, very low, 0.09 and about 0.2%. That's sub-Saharan Africa. That was a paper that was published by these guys. It's a systemic review, and they excluded South Africa being a different country of its own. Of course, we're not comparing with any other sub-Saharan country. Of course, in Uganda, we are really seeing an increasing number of these cases. We used to do about 2 to 3 cases per week, but now we're having an average of about 2 to 3 per week. So averagely, we are doing about 100 arthroplasties a year. And of course, even the private setting around, and even the government setting, they are doing these cases. I mean, which is partly explained by, of course, improving quality of life. I mean, the people are living longer, and of course, the economy is also improving. In terms of why adequate pain control in these patients, why do we have to control this pain? When we control this pain adequately, of course, yeah, you see patients staying spending a little time in the hospital. You decrease the costs in terms of the drugs that you're using. Of course, yeah, you decrease the morbidity, mortality, and of course, improved long-term functional outcomes. And of course, yeah, you decrease the hospital falls, and it decrease surgical site infections. And yeah, you reduce the amount of blood that has been lost. And of course, we say acute pain that is not well controlled is a risk factor for chronic pain. And yes, most of the time, patients are satisfied when you adequately control their pain. They will really appreciate at the end of the surgery. If you had introduced yourself at the beginning or when you're doing a pre-op, they will be able to recall your name. If you had introduced yourself and probably you didn't control the pain adequately, the following day they will not be able to recall you. So if you control your pain adequately, the patients are really satisfied. If you inadequately control the pain, because we know the several systems are affected, ranging from the CVS, of course, they have increase in the heart rate, peripheral vascular resistance, BP is going up, and if there's a patient that has reduced physiological reserve in terms of they have ischemic heart disease, then they are at risk of getting myocardial infarction. This is in general, if you're working on, let's say, the abdomen and the chest, they will have diaphragmatic splinting and reduce vital capacity, impaired ventilation, and later atelectasis, and then pneumonias or hypostatic pneumonias. And then, of course, you have hypoventilation and increased VQ mismatch. And this will lead to sepsis and, of course, increasing oxygen requirements and later infections. For the GIT, you have decreased motility, and they will end up with paralytic ileus and nausea and vomiting. And then, of course, they will end up with urinary retention. And in the coagulation system, of course, you'll have increased platelet aggregation. You'll have venous stasis. This puts the patient at risk of DVT and later thromboembolism. They will have kind of muscle spasticity or muscle spasms because they don't want to move and they want to be in a limited space. They don't want even to turn, and that, if it's prolonged, they end up with muscle atrophy and, of course, yeah, fatigue. And of course, the joints also become stiff if you have not adequately controlled the pain. And in the long run, they have disability. Psychologically, many of them may be depressed and they have the anxiety and, of course, the fear. The next time they may not be able to come back, or if they have friends that they share information with, that may put a negative attitude about the surgeries that they were supposed to undergo. In the overall, there is delayed recovery because they stay in the hospital longer, and then there is delayed return to normal life. They get into this cascade of chronic illnesses. So before we look at the pharmacology and the anatomy, I would just like us to just have an overview of the innervation of the knee, specifically because we are starting with the knee. About three major nerves. We have the femoral, which runs down the femoral triangle into the adductor canal as saphenous, and then to give the genitular branches to the knee. They have the superior medial genitular nerves, and then we have the spirolateral genitular nerves. We have the superior medial here, and then the lateral here. And that is still, and then of course there will be an inferior medial genitular nerve That's still part of the saphenous, which is a continuation or a sensory continuation of the femoral. And then we have, of course, the branches of the sciatic, that is the tibial and the common peroneal, that run posteriorly to the knee, and they will give up articular branches to the knee. And then we have a variant, that's the obturator, the posterior division of the obturator nerve, which is assumed to run through the adductor canal, also supplying the knee. So once you know the innervation of the knee comprehensively, and then you can ably control the pain for these particular patients. Innervation of the hip, basically from three major nerves. We have the femoral, we have the obturator, and then we have the sciatic. The femoral contributes almost 80%. And we look at the various areas where it innervates when we are doing a particular block. But in general, just know that there are about three nerves that innervate the hip, and that's femoral, obturator, and then the sciatic. But before we get into the regional aspect, there is a concept of the multimodal analgesia. I guess many of you have heard about this concept, which was coined by these guys around 1993. And basically that what it means, you have a number of drugs that you're using that act at different sites, and they have kind of a synergistic effect, and that will kind of reduce the adverse effects if you're using a one sole analgesia. Let's say in this particular case, most of the time we're using opioids. So these regimens must be tailored to individual patients, of course, keeping in mind that yes, this is a procedure that's being done, and of course the side effects and the patient's pre-existing medications. You need to have thorough history about your patient, and you need to understand your patient very well as you're prescribing or you're doing the multimodal analgesia. Yes, we've seen this, the concept of multimodal analgesia, as we said, various sites, drugs with different mechanisms. Yes, we have the process of transduction, where you have release of mediators of inflammation, bradykinin, the histamine release at point of injury, in this particular case, the surgical insult. And that's where mostly our anti-inflammatory agents will work, and that's the NSAIDs. We have COX-1 and COX-2, and then the non-selective. So most of them will work peripherally here. And then we have that aspect of transmission, where you have this impulse generated and it's transmitted to the spinal cord, or the dorsal horn of the spinal cord. And then you have your local anesthetics acting in this particular area. When you do nerve block, you're basically blocking off the transmission. When you do a spinal, when you do an epidural, you're basically blocking off the transmission. And then you have, of course, yeah, local anesthetics also acting centrally at the spinal cord, and that's using the local anesthetics, and also the opioids. We have the opioid receptors and the alpha-2 agonists like clonidine and dexmedetomidine, and even ketamine. We have those receptors centrally. And then, of course, yeah, we have perception and modulation, which is at the cortex level, and where we have these opioids acting centrally. So you have the transmission, transduction, transmission, perception, and modulation, and we have drugs that are acting at each and every stage of the pain pathway. The treatment modalities, yes, patient education is very, very important. When you're doing your pre-operative assessment, it's very, very important that you take your patient through the mode of anesthesia and your pain management plan. They need to know this very well. They need to know the good things. They need to know the side effects, the complications, so that by the time they come, they are aware of what they are supposed to go through. And then, of course, yeah, we administer these medications pre-operatively, what we call preemptive analgesia. And of course, we have the neuralgia analgesia, where we have continuous epidural, combined spine epidural, and then we have the peripheral nerve blocks, and then we have the periarticular injections. We have both the oral and intravenous analgesics, and then we have the patient-controlled analgesia, which could be intravenous or epidural, or you have a peripheral nerve catheter that has been inserted. This is just an elaboration or an illustration of the treatment pathway or pain management pathway in both the hip and the knee. Partly is from the ASRA, they came up with this, and indeed a number of physicians, a number of perioperative physicians have used this, and it's very, very effective. We are using this at CoRSU. We have, of course, if you're doing a total hip replacement and knee replacement, these major arthroplasties, preoperatively, about 2 hours before the surgery, the patients will get acetaminophen, and that's paracetamol, celecoxib, and then pregabalin. That's about 1 to 2 hours before the surgery. And then, of course, once into the operation room, depending on which modality of anesthetics you have chosen, if you've chosen spine anesthesia with intrathecal morphine, if you have chosen combined spinal with extended release morphine, that's okay. If you've chosen combined spinal with a little bit of, I mean, you're trying to keep away from the opioids, yes, that's also very fine. You could choose the general anesthesia. But of course, yeah, this is combined with either a nerve block, which could be femoral or femoral and sciatic, and other nerve blocks that, if the patient has consented to that. And then for the knee, you could have a spinal, just spinal alone. You could have a spinal with some morphine. You could have spinal with extended release morphine. You could have a combined spinal, yes, with extended release morphine. And then you could have a spinal with a femoral nerve block, which can be done at induction. As soon as you put in your spinal, you can have the femoral nerve block done. Sometimes these surgeries are prolonged depending on the complexity of the surgery. You anticipate the surgery to go for 2 hours, but it runs maybe for 3.5 hours. But when you put in your nerve block, you kind of buy time. They will have the surgery and complete it. So once that surgery is done, then you have the post-operative period. Still, you could opt to do epidural, a continuous epidural for pain management, but still this comes back to monitoring. Many times we have human resource gaps. You're not going to have a patient just on a ward with epidural catheter in, and you're running local anesthetics without at least hourly monitoring of the vitals. Many of our patients may be getting 6 hourly vitals. So you need to be very careful as you're leaving the epidural infusions running. Alternatively, you could have a nerve block, let's say a femoral nerve block, which could be continuous. It could be a single shot in the OR, but you could choose to leave in a catheter and you run an infusion. That's a little bit safer as compared to having an epidural running on the ward. And then, of course, you usually have the other modalities. We have the acetaminophen, the non-selective. If you don't have the selective or CoRSU, and you have only the non-selective CoRSU1 and CoRSU2, then you could use that. And depending on the patient's medical condition, if they don't have any contraindication to the non-selective, we usually combine with pregabalin or gabapentin, whatever you have, for the next 2 to 3 weeks, as long as usually they stay within the hospital for about a week, and then they are discharged. They usually go on these medications. You could have the intravenous patient-controlled analgesia, or you could have the patient-controlled, but with an epidural infusion, or patient-controlled with a peripheral catheter running. So those are that's just the illustration of the treatment modality when we are addressing pain in these particular cases. Yes, the NSAIDs, yeah, we know very well that they inhibit prostaglandin production. which could be reversible or irreversible. And yes, there is documented evidence of decreased opioid consumption and improved outcomes in these kind of surgeries. It's ideal, yeah. Usually they recommend that if you're prescribing the NSAIDs, they should continue with the CoRSU for about 2 weeks. This coincides with the duration of the inflammatory process from the surgical insert. Very important that you understand your patient's history, as they are at risk of getting renal insufficiency, since many of them are elderly and they may be on a number of medications and they have other comorbidities. And yeah, many of them may be having a history of peptic ulcer. So you need to be very careful as you're prescribing. This can be actually picked from the history as you're doing your pre-op assessments. Paracetamol, centrally, it inhibits the prostaglandin synthesis. So with minimal inhibition peripherally, as we all know that yes, when you combine paracetamol and the NSAIDs, the combination really confers superior analgesia than if you use either drug alone. And yes, the bioavailability is kind of reliable, and the onset usually within 30 minutes you should be able to have the paracetamol kick in. Usually the duration is about 4 to 6, and you shouldn't really exceed say 60 milligrams per kg per day. That's about 3 grams per day. As you said, yes, the gabapentinoids, that's pregabalin and gabapentin, they are finding their way in acute pain management. Initially, we knew them as drugs for chronic pain and epilepsy, but yes, studies are showing that yes, they can be used in the acute pain management. We've seen studies in the gyne, spine, and now the arthroplasties. Basically, the mechanism of action, they inhibit the release of the excitatory neurotransmitters, substance P and calcitonin G-related peptide. And of course, yeah, they also inhibit calcium influx via the voltage gated channels. Extensively, yes, they kind of decrease the incidence of chronic pain after the arthroplasties. Here are some of the studies, the benefits of pregabalin in the acute pain treatment through the systematic review. And significantly, there is a significant opioid consumption, and of course, reduce stay in the hospital, and mobility is kind of they're able to mobilize much faster. The only thing that it came up is when they use bigger doses, many of the patients get sedated. As big as for gabapentin, I think as big as 1,200 milligrams, and then the other one is about 300. So as you're prescribing them, usually about 150 of pregabalin, and for gabapentin about 300 milligrams is good enough. Yes, we're at one time we're also using big doses. For gabapentin, we're using about 600 per day, and most of the time, post-operatively, our patients were quite sedated. They needed oxygen supplementation, and they stayed longer in the HDU. Most of the time, they go to the ward, but this time around, they were staying in the HDU, and we decided to just scale down to 300 of gabapentin. And they, when you talk to them in the morning of the surgery, they say, I had a very good night. I'd never slept like this. So it's a good thing when you do the multimodal Analgesia Ketamine, which is one of the most common drugs that we routinely use in anesthesia and critical care. Yeah, we know very well that it's an NMDA receptor antagonist, and basically it's involved in nociceptive pain transmission and central sense. It prevents these from occurring. One of the advantages of using ketamine is that it's a potential for the anti-hyperalgesic. It kind of prevents the anti-hyperalgesic. It's anti-hyperalgesic. And as we know very well, NMDA receptors with hyperalgesia. So we usually, if the patient has been having a chronic osteoarthritis and it has been kind of disturbing them, and the patient is coming for arthroplasty, over and above what we do, we usually run a low dose ketamine. That's as low as 1 mic per kg per minute, or 0.1 milligram per kg per hour. And that usually goes for about 24 hours, 24 hours to 48 hours. But many times they want to ambulate the following day, so we usually run for about 24 hours. High dose ketamine has been implicated in causing the psychomimetic effect. That's as high as 2 milligrams per kg, causes nightmares, hallucinations, and the excitatory phenomenon. And of course, yeah, increased secretions and nausea and vomiting. Yes, low dose, very good during the perioperative period, as may reduce the incidence of chronic pain. Even a number of, I mean, it's been studied in spine surgeries, and we use it quite a lot in some of those extensive surgeries where we think pain management is going to be an issue, and probably you can't do a block, because if it's a mild innervated area, then you may need to bring in the ketamine infusions. It's relatively safe, even on the wards, as long as you've set very low doses. I mean, a patient may be getting like 2.5 milligrams per hour, which is quite a small dose, and they're kind of comfortable. So in the post-op pain management, yeah, we can use the peripheral nerve blocks or the epidurals. Yes, the epidural as a modality of pain management used to be the gold standard. Setting a lumbar epidural, then you run an infusion of bupivacaine, probably 0.25%, and yes, it gives you very good results. The pain management is very good, but now we have an increasing population, and that they are elderly, and many of them are on a number of anticoagulants. So if you have a patient who is on a number of the high risk of forming a clot of DVT, and then you want to run an epidural infusion, yet when you continuously run the infusion, they are at risk of getting a epidural hematoma. So you kind of weigh, would you do the epidural, you do run the epidural post-operatively, or you do a peripheral nerve? They're kind of replacing the epidural infusions with peripheral nerve blocks. And then usually we add the epidural morphine or any other opioid that you may be adding. Usually they end up with extensive itching, urinary retention, and they are kind of nauseated. So all these, well, you could run the local anesthetic alone, but many times we combine so that we reduce on the amount of the local anesthetic that we are using. And then of course, we know very well that we have hypotension from the epidurals. So it may not be a good thing if you have a patient probably on the ward and with minimal observations that are being taken. We have also catheter-related complications. I mean, they tend to migrate, maybe unilateral, could puncture the dura, and you end up with a spinal. So you're running all these volumes of local anesthetic, probably maybe 8 mLs, 2 at the intrathecal space, and that can easily give you a high spinal or a total spinal. Well, dead if it's not recognized. So why peripheral nerve blocks? Yes, they have shown to reduce perioperative complications. The patients are kind of mobile and reduce the incidence of course, the DVT, and you reduce the time to discharge. You can easily discharge the patients from the hospital. And then of course we know very well that we conserve the hospital resources and improves patient satisfaction. If yes, in an epidural, yes, if you do an epidural, yes, your patient will be satisfied. But again, when you added an opioid, they may be either sedated, they may be nauseated, and you may have to add an antiemetic, you may have to do oxygen supplementation, you may have to look for medication to relieve the itching because it can be that bad. yeah, so if I'm moving away from the central, they are going to the periphery, and that's life. So we have one of the modalities that we use for both the knee and the hip. It used to be one of those methods, but now they are moving away. That's the lumbar plexus block. We know very well that stretches from L1 to L5. And yes, when you do the lumbar plexus block, you have complete unilateral analgesia for patients that are undergoing total hip. If you do a lumbar plexus block plus a sacral plexus, then you can have a hip surgery and knee surgery because you're blocked off the sacral component. So for the knee, yes, this is sufficient, but it's considered to be a deep block. In fact, the contraindications for an epidural for patients that are on anticoagulants, yes, you may actually consider them even for lumbar plexus. And it's a complete kind of an advanced procedure with potential for serious complications. We know very well that retroperitoneal, we have the kidneys, we have the epidural space. And if you're not very careful, you can puncture and end up with a retroperitoneal hematoma and also a spread. But it's something that we do. I mean, we've done them for patients that have come in and probably they are in septic shock. But they require a surgery on the lower limb, let's say the knee or the femur. Then you could do a lumbosacral plexus, and they're kind of comfortable. So it gives you very good analgesia, yet maintaining the hemodynamics. So if you have a very high risk patient, I mean, this would be a good block for you to do, both for surgery and also for analgesia. Yes, the risks of hematoma formation in anticoagulants patients, it's really high, especially if you have patients who are on multiple anticoagulants. You have to think through it. And because we're using volumes of local anesthetics for this plexus, probably about 20 to 30 mL, is a risk of local anesthetic toxicity. And also that area is highly vascularized. You're depositing the drug in the posterior third of the psoas major muscle. And it's highly vascularized, so you are at high risk of getting the local anesthetic toxicity. Yes, there have been risks of inpatient falls. In the developed world, when they do the arthroplasties, they want the patients to ambulate. Actually, they start the rehabilitation process in the afternoon of the surgery. If the patient has had a surgery in the morning, then in the afternoon, they want to start rehabilitating them. That involves flexion and extension of the joint, and of course, so ambulating around the bed. And that is a risk if you've done a lumbar plexus block. Let's say you've done it for knee arthroplasty, or if you've done a lumbar epidural, and probably use maybe a bigger concentration, the patient is at high risk of fall. One of the nerve blocks that we usually do for the knee is the femoral nerve block, which could be a single shot or a continuous. Single shot, yes, you locate the nerve, put a local anesthetic around the nerve, and that's it, probably with an adjuvant. And then for continuous, you're leaving in a catheter. We just had a clear illustration of how these catheters operate. And then you tunnel it and saturate it. And then you're going to run an infusion of, let's say, bupivacaine or ropivacaine post-operatively. It's one of the nerves that I would say one of the P blocks that every anesthesiologist should know. Because when you have a patient that is undergoing the knee or the hip, that alone really kind of cuts your opioid requirements by almost 50 to 80%. So it's relatively simple block. It has shown higher success rates. It carries a low risk for complications. If you do a single shot, probably it may last for about 24 hours. That's if you're using bupivacaine or ropivacaine. As we said, 80% of the knee is supplied by the femoral. So if you do a good femoral nerve block, your patient should be comfortable in the recovery room with the other modalities of multimodal analgesia, paracetamol, and NSAID, and probably gabapentin or pregabalin, they are kind of comfortable. The only aspect that is missed out is the posterior part of the knee, that's from the sciatic. However, there have been increased instances of falls if patients have had the femoral nerve block. And of course, there are case reports of catheters dislodging, and of course, infection and nerve injury and prolonged motor weakness that may occur if you're running infusions beyond 48 hours. So cumulatively, there is that prolonged motor weakness, and that kind of brings down the rehabilitation process, because these patients are supposed to ambulate at least within 24 hours. They should be able to start the physiotherapy. So how do we do the femoral nerve block? Usually ultrasound probe, which is a high frequency linear probe, is placed in the inguinal crease, and in the transverse, you cut in a short axis. So you'll be able to visualize the femoral artery. The vein is somewhere here, which is compressible. And then you'll be able to visualize the fascia lata, which is the superficial fascia. Then you have the fascia iliaca, the deep fascia. And the nerve is an oval structure that sits on the iliopsoas. It's highly anisotropic. When you are holding your probe, it takes shape, it takes different shapes. So it's basically seated on the iliopsoas. If you've done a scan and you're seeing a number of vessels in the inguinal crease, it means you're too distal. So you have to scan proximally until you're able to see a vein, artery, and the nerve. Usually the nerve lies below this fascia iliaca. There is a tendency of depositing the local anesthetic just close to the artery here. You miss the femoral nerve. It's usually enclosed by the fascia iliaca in this muscle. So usually the needle trajectory is under the nerve right here, and then above the nerve. And that is for the knee. Even for the hip, yes, we can do this, but many times we may miss out on the articular branches to the hip. So, but it can be done at the inguinal crease. And that's just the needle trajectory under the nerve and above the nerve. So as we've seen, when you do a lumbar plexus, when you do a femoral nerve, there is progressive motor weakness, and yet you want to ambulate these patients quite fast. They came up with what we call the adductor canal block, or the Hunter's block. This is specifically blocking the sensory aspect of the femoral in the adductor triangle or the adductor canal. As we said, through the femoral triangle into the adductor canal, you have the saphenous, and that's what you're interested in. The terminal sensory branch of the femoral nerve located within the adductor canal. When you compare studies that have been done, they're comparing the analgesic potency of femoral to the adductor canal. It's kind of comparable, very comparable, yet with minimal motor blockade. So you have a patient that is able to ambulate, and they have very good analgesia. So this is the nerve block of choice for knee surgeries. They're able to ambulate, and the pain is as well addressed. And usually it's a low volume local anesthetic. I mean, low volume block, about 5 to 10 mLs. For femoral, yes, about 10 to 15 mLs, or as high as 20 if you're starting, but usually 10 to 15 mLs or 0.25% should be able to give you good analgesic effect. So if you're doing the adductor canal block, usually the probe is placed mid-thigh, and you scan medially, you'll be able to see a boat-shaped like muscle, that is the sartorius. And then you have the vessels. You have the femoral artery and then the femoral vein. Lateral to these vessels, you will see the saphenous nerve. So in this canal, you have the saphenous nerve, you have the nerve to vastus medialis, and they say sometimes you have the posterior branch or posterior division of the obturator. So when you place the local anesthetic here, you will have the blockade of those three nerves. And that's why we have minimal motor blockade. You're blocking off a nerve to vastus medialis, but with comparable analgesic effects. So you do adductor canal, you've covered almost 80% of the pain management for the knee. The other nerve that supplies the knee is the sciatic, and basically here you're blocking. You could either do a subgluteal nerve block, or you could you're doing a transgluteal nerve block just way above the thigh, or you could do mid thigh, or you could do popliteal nerve block, and that's still the sciatic. But you say it's controversial in regard to its usefulness for patients undergoing total knee arthroplasty. Why? Because it causes prolonged motor weakness. Because when you combine a sciatic with the femoral, you'll have a limb that is very weak, that the patient cannot be able to ambulate. And if you've done a sciatic nerve block, it may be very hard to detect a nerve injury that is induced by the surgical technique. So there's a delay in the detection and also, of course, the treatment if there is an injury to the common perennial. That's why it's controversial. However, when you do it, both the sciatic and the femoral, or sciatic and the femoral nerve block, the patient will be very fine as far as pain management is concerned. Studies have shown there's reduced opioid consumption when you combine the femoral and the sciatic. And of course, if you place in a catheter, patients are very comfortable post-operatively. The other modality that has been used, as we've seen, motor weakness is a big limitation to some of these major nerve blocks. So there are infiltrative techniques. One of them is when the surgeon does the infiltration. They provide site-specific analgesia where the patients are able to ambulate without motor weakness. Sometimes they place in a catheter and you run an infusion post-operatively of some bupivacaine, so which could be done by the surgeon. And then sometimes they can insert the wound catheters, and still this has proven to bring about very good analgesia, reduce opioid use, patients are satisfied, and of course reduce hospital stay. And there is a consistent evidence, as we said, for effective analgesia and opioid sparing. This is if you're not able to, you don't want to have this prolonged motor weakness and probably you want to ambulate. Sometimes patients want to go home within the next 24 hours and 48 hours, but we've not reached that extent in our setting here. But in the developed world, they are discharging patients after 48 hours, they are going home. And these are some of the modalities that they are using. So because of the progressive motor weakness, that if you, let's say you've done a femoral and a sciatic, you'll end up with a motor blockade. Let's say you've done a adductor canal and you've done a sciatic, you'll end up with motor weakness. We've come up with a newer block that they call the Eyepatch, and that is infiltration between the posterior artery and the capsule of the knee joint. What that entails, you're using a longer needle, which could be a spinal needle that you're passing, or the needle trajectory is between the intercondylar space, that is the femur, and the popliteal vessels. You have the popliteal artery, you have the popliteal artery and the vein. So your needle trajectory is of course from the medial aspect through the vastus medialis, and then you're running in that space between the vessels and the capsule of the knee joint, and you're depositing a local anesthetic right out from the other end to the medial aspect, from the medial lateral. So you're moving from the lateral, infiltrating all the way. In this way, you're blocking off the articular branches of the sciatic, not the sciatic itself, but you're blocking off the articular branches of the tibial and the perineal. And specifically, you're not altering the motor blockade. You're not doing the motor blockade. So it selectively anesthetizes the distal ends of the articular branches while sparing the motor. And of course, yeah, there is early ambulation and there's muscle sparing. So you can do a femoral or adductor canal with the Eyepatch block for the knee surgeries, and the patients are comfortable. And usually we prefer doing this Eyepatch block before the surgical incision. Before the surgery is done, you do your blocks, and then they can go on with the surgery. Since most of the access is anterior, you're actually placing your local anesthetic posteriorly, so they will not be able to complain that you injected the local anesthetic in the surgical space. So block ergonomics, you have a patient that is lying spine with the knee flexed, and you're placing your probe medially around just about 2-3 centimeters above the knee and medially. So you're able to see of course the femur here. You have the vessels, and this is your trajectory. If you see a transection or cross section of the needle trajectory, you have the vessels here. You have the muscles, the hamstring muscles, the sartorius semitendinosus, where they insert, and then you're passing your needle just between the knee capsule and the popliteal vessels, and that's the Eyepatch block. It's quite simple. You're not visualizing any nerve. You're dropping the local anesthetic in that space. Yes, so there's Eyepatch versus the periarticular mild modal drug injection. This is usually done by the surgeons. There is a concoction that surgeons usually use. You have the local anesthetic, you have epinephrine, you have an NSAID, usually ketorolac, and some morphine in it. So they infiltrate at the knee joint. Basically, all this is aimed at, of course, attaining the analgesia, but also minimizing the motor blockade. So we're comparing the Eyepatch with the periarticular mild modal drug injection. That's if they're using local anesthetic and opioid and NSAID and epinephrine. Studies have shown that yes, there is significant reduction in the pain levels in the Eyepatch group as compared to the periarticular mild modal drug injections. So that's basically the regional techniques for the knee. Moving on, we very well know that yes, the hip is supplied by about 4 nerves. That is the femoral nerve, which supplies the anterior and the lateral aspects of the hip capsule. We have the obliterator that supplies anterior and the medial aspects of the hip capsule. And then in some patients, we have the accessory obliterator nerve that contributes about 10 to 30%. And that innervates the inferior medial aspect of the hip capsule. And then of course, usually the incision is lateral. The cutaneous innervation of the anterolateral thigh, that's by the lateral femoral cutaneous nerve of the thigh. The posterior aspect of the hip is supplied by the branches from the sciatic and some of the branches from the sacral plexus, and that is the superior and inferior gluteal nerves. And of course, then the branches from the quadratus femoris. So that is the general overview of the innervation of the hip. This brings us to another block that has come up specifically for the hip. And that is the so-called pericapsular nerve group block. And that's a technique that involves depositing the local anesthetic in the musculofascial plane between the psoas muscle and the superior pubic ramus. Yes, we've seen femoral nerve block and the fascial compartment blocks being used for analgesia, for hip, and also knee surgeries. But the only limitation with the femoral nerve block, the articular branches to the hip kind of originate at a higher level along the course of these nerves. So these blocks may not provide sufficient analgesia for the hip fractures. And that is the only limitation with the femoral nerve block. Yes, we do it, but also when you're doing it, you've got to make sure that you are more proximal than this. So if you more distally, you miss out on some of the branches. So this has created a gap as far as pain management is concerned. And that's why we have the pericapsular nerve group block that basically involves depositing the local anesthetic and the anterior aspect of the knee capsule. You have the iliopubic eminence, you have the iliopsoas muscle. Then usually there's a tendon, a psoas muscle tendon. Right when you're scanning, you put your probe around the femoral crease and you kind of undulate it medially, and then you'll be able to see these structures. You'll be able to see the iliopsoas notch, and then you have the anterior inferior iliac spine. Of course, up here you'll have the superior iliac spine. So your local anesthetic is deposited in this plane, and in that way you're blocking off the articular branches of the femoral. You're blocking off the articular branches from the orbiturator and then the accessory orbiturator nerve. This is where you deposit the local. It's a newer block that has come up, and of course, yeah, people are using it in the perioperative setting, but also in the chronic pain management, and of course, even doing radiofrequency ablations for these patients with hip arthritis, that is, and they cannot access the surgical intervention. The fascial iliac block, we've done this. I think there's an old block. It's an alternative to the femoral nerve and a lumbar plexus. Basically, you're targeting it's the so-called 3-in-1 block. You're blocking the femoral orbiturator and lateral femoral genius. But studies have shown that you cannot reliably block all the three nerves. You may block the femoral and lateral femoral genius, but you may not be able to block the orbiturator. So you'll have that aspect of innervation not being blocked. But the goal is basically to place the local anesthetic just under the fascia iliaca. And that provides analgesia for the hip and even for the knee surgeries. But now, if you have an ultrasound and you're able to visualize the femoral, you're able to visualize the lateral femoral genius, why not deposit the local anesthetic around the nerve other than depositing the local anesthetic in a fascial plane? It's a compartment block, so you don't have control over the spread of the drug, but it's done and it's proven to be very effective. So basically, you have the iliopsoas, you have the femoral nerve right here, and then this is the compartment that you're depositing the local anesthetic. You have the sartorius muscle here. This is the lateral aspect. So you're depositing the local anesthetic here with the hope that it will spread around the femoral and block the lateral femoral genius nerve this side, and also block the orbiturator down this side. The orbiturator nerve, said it's one of the nerves that innervates the hip, and kind of variable innervation to the medial aspect of the thigh or the knee joint. Has two divisions. We have the anterior and posterior, and the anterior division lies between those adductor muscles. We have the adductor longus, adductor brevis, and adductor magnus. So the anterior division, which innervates the hip, or which provides articular branches to the hip, runs between adductor longus and adductor brevis. And then the posterior division runs between adductor brevis and adductor magnus. And this is how the muscle layers are. If you put your probe medially around the perineal area, but in the transverse section like this, we'll be able to see three muscles: adductor longus, brevis, and magnus down here. So the anterior division of the obliterator runs between the adductor longus and adductor brevis right here, and that innervates it provides branches to the hip. And then the posterior division right here runs between adductor brevis and adductor magnus, and that provides innervation to the medial aspect of the thigh. So that if you block the femoral, you block the obliterator, you block the accessory nerve, you're remaining with the sciatic or the innervations from the articular branches from the sciatic or the sacral plexus. That can be catered for by the other aspects of the multimodal analgesia. So other modalities that have kind of helped as far as pain management is concerned in both the knee and the hip surgeries is what we call cryoneurolysis of some of the genitular nerves. And as we said, we looked at the genitular branches of that's supplying the spirolateral spiromedia aspect from the saphenous. We kind of apply ice towards those nerves or on those nerves, and that kind of, they say it reduces the inflammation, metabolism, and of course nerve conduction, and hence the analgesia. Then we've had the TENS, transelectrical nerve stimulation of those articular branches, and of course, yeah, nowadays the transdermal fentanyl that could be prolonged, and for about 3 days you have intermittent release, and the patient is kind of pain-free, but you have the other side effects of the opioids. We have the extended release morphine that can last for about 48 hours. And then we have now the liposomal bupivacaine that kind of can be used for infiltration and gives you relief about 72 hours. But still, studies are still ongoing. I've not seen it being used intrathecally. These guys, the ASRA guys and American Pain Society came up with some of the guidelines as far as post-operative pain management is concerned. And still, they are very, very effective when we adhere to them. Yes, we need to advocate for multimodal. And of course, the non-pharmacological techniques, as we said, the TENS, and of course, the behavioral aspects. They recommend use of opioids, oral or IV, not necessarily the IM, because when you're doing the IM, you're inflicting pain, and of course, you're not sure of the absorption. Intravenous, patient controlled, yes, that's very good. But usually I don't recommend, if you're running the PCA, you don't recommend the basal continuous infusions. And yes, they recommend use of the NSAIDs, so acetaminophen, and pre-op use of the selective ones like celecoxib. It's very good. They recommend that, and of course they recommend use of the gabapentinoids. That's gabapentin and pregabalin. And when you're doing an nerve block, it's very good that you infiltrate or you topically apply some EMLA, but it's very good to infiltrate. Yes, that's the general overview of the acute pain management for both the knee and the hip. Specifically, if you're doing the hip, if you've done the femoral, or if you've done the hip block, you are good to go. And the patient is kind of comfortable. Thank you so much.
Okay, thank you, Kojjo. So today's talk has been on acute pain management for patients following hip and knee arthroplasties. I can see some orthopedic surgeons were in attendance, which is quite good. So, like I said, you can use the Q&A section to type your questions. So I have some questions. Earlier on, for those that missed, we had a talk from B. Brown. Those are our friends of anesthesia. They help us a lot, and they sponsor some of the conferences that we have. So I have a question from Dr. Jeremiah. This is for you, Kojjo. So his question is, given as following hip and knee arthroplasties, the surgeons usually want the patient to ambulate in the immediate post-operative period. If you did an epidural and then a peripheral nerve block rather than ITM, wouldn't that affect ambulation? Kojjo?
Yes, thank you, Andrew. Yeah, if you
Yes,
did an epidural with a local anesthetic, rather than ITM,
if you did an epidural with local anesthetic rather than ITM, wouldn't that affect ambulation in the immediate post-operative period?
Yes, when we were starting the presentation, we gave some should I say, the advantages of doing an epidural versus a peripheral nerve block. But if you have done an epidural, and depends, first of all, the concentration of the local anesthetic that you've used, and in the immediate post-op, there may be a residual effect of the epidural, and that means there will be a lower limb weakness. Well, if you've used a very small concentrations, the patient may be able to ambulate with support. But if you think they're going to ambulate the patient in the immediate post-op, then you'd rather do a nerve block that has a motor sparing effect. Let's say you do an adductor canal block with an infiltration in the posterior aspect of the knee. That's the Eyepatch. Yes. So you have to be very, very careful, because if the patient falls, then you are responsible.
Okay.
Yeah.
So the other question is regarding the gabapentinoids. It's from Dr. Peter. So there are about three. One, what is the dose of gabapentin and pregabalin, either or? What dose do you use that will give you the desired effects and less of the undesired effects, that is sedation? Then two, at what point should you give it? So you said 1 hour. Therefore, that give it the day before surgery when you're doing your pre-op assessment. You tell the patient to follow the pregabalin. Then in the morning as well before surgery. So what is the optimal time for administering this drug? Then three, does it have a role, since most of the patients you work on for total hip and total knee replacement are usually elderly with various comorbidities, some of them requiring gabapentin? Is there a role of this additional gabapentin before surgery for someone who has been on gabapentin or pregabalin? And then five, what is your preference? Do you use pregabalin or do you use gabapentin?
Yes, thank you so much. About the optimal dose, initially we were using what actually has been recommended as high as 600 to 1,200, but realized most of the time the patients were kind of dizzy, kind of dizzy, exactly, as sedated. So we kind of scale down. We do 300 twice a day. You'll have a night before. That's if they came into the hospital a night before. They will have a night before, and then in the morning of the surgery, and then later in the evening. That's what we've used, and we're using gabapentin partly because of the cost implications. Pre-GABA is much more expensive than the gabapentin, but of course, in terms of potency, pregabalin is superior to gabapentin. The timing, yes, different schools of thought, but we usually start a night before the surgery. And if the patient has been on these medications, I see you may not be able to adjust. I mean, if they have been on the medications, and why would you? Probably you may increase the dose, but again, increasing the dose may give you other effects, lesser sedation, and because they have dry mouth, and also putting into consideration of the organ function. If they're elderly and probably have renal insufficiency, then you may not need to give very big doses of the GABA nutrients. Yeah.
Okay. So if you were to use pregabalin, what dose would you use?
Pregabalin, we usually do 150. That's 75 and then 75 in the evening. Because if you give a single dose, let's say 150, on top of that, maybe they may be also getting an opioid, or probably you're putting some ITM. They may be quite sedated, and especially if they're not in a setting where they are closely observed, they may have some bit of hypoxia or hypoventilation. So they need some bit of oxygen supplementation. Yeah.
Okay. So I have two other questions. So what's your experience with ketamine infusions during the operation and in the immediate post-operative period? Then we have a question from Peter Waspa. He's wondering whether you have heard of intrathecal ketamine and intrathecal midazolam used as adjuvant for this. Have you done it? Did you see this being done during your extra training?
Yes, for ketamine infusions, we've not used them pre-operatively, but we've used them intraoperatively and post-operatively. The doses that we've been using are very small doses, such even within the intraoperative period, the patient are not significantly sedated and they do not have the psychomimetic effects. Usually about 2.5 to 5, that's about 1 mic per kg per minute. And post-operatively, if we've done, let's say, a very good nerve block and we are sure it was good, then most of the time we don't run the ketamine infusions. But if the patient has been having this chronic osteoarthritis, they have come in immobilized, we've done a nerve block, many times we run a ketamine infusions. And also, of course, on top of that, we give antiemetics. We usually run it for about 24 hours. The following day, we discontinue. And on top of that, we also add the gabapentin. And they're kind of comfortable. They rest very well. They're not restless. They don't report hallucinations. They will actually say that we had a very good night. Thank you. We've never had such a peaceful night, especially if they have been in a lot of pain pre-operative. Yes,
okay. So
most of the studies that
intrathecal ketamine.
Most of the studies that I've seen, they don't really recommend use of intrathecal ketamine or midazolam because they are neurotoxic. Studies have shown in animal studies, and I don't think whether it's recommended to use the intrathecal ketamine and the midazolam. Yeah.
Okay. Even if you got a preservative-free version of those two drugs, you wouldn't use it?
Because studies have shown that they're neurotoxic. So whether it has a preservative.
The drug itself, huh?
Yeah.
Okay. Yeah. So the lumbar plexus block is easier to perform on its own. The sacral plexus is quite difficult. So if you were to do a lumbar plexus block and supplement with, say, a sciatic nerve block, how high would you go for the sciatic nerve block? And then if you had one of the elastomeric pumps, what rate would you set for a lumbar plexus nerve block, continuous infusion?
Yes, thank you. If you manage to do the lumbar plexus block, depending on what you're using it for, the indication, if you're doing the lumbar plexus specifically for the hip, and then probably the sacral plexus, they recommend that you use a dual method. You use an ultrasound and also a peripheral nerve block. I mean a nerve stimulator and then also an ultrasound. So if you're using an ultrasound, I mean, if you're able to locate a sciatic nerve transgluteally, and then you just move a few centimeters proximally, you should be able to locate the sacral plexus. Much as you may not be able to see a well-defined structure, like the way you would see, let's say, a circular sciatic nerve, you should be able to follow it. And some of the landmarks that usually use, of course, you have the piriformis down there, but you also have the arteries, the vessels, that is the superior gluteal, and also I think the inferior gluteal somewhere. So if you're able to locate the transgluteal sciatic, you should be able to locate the what? The sacral plexus up there. It's much more clearer in children. If you want to learn to do these lumbar plexus, sacral plexus, you will appreciate them much more in children, because you can even actually use a high frequency probe and you're able to locate this sacral plexus. If you're doing it for the knee, this alone, the lumbar plexus block should be actually sufficient for the analgesia, and then you just do the infiltration posteriorly for the posterior aspect of the capsule. If you have the elastometric pump, very good. If you have the elastometric pump, you've loaded your local anesthetic depending on the concentration that you've used, and most of the time I think you're using the analgesic dose, probably 0.25 or 0.125%. And of course, when you're calculating, you put into consideration of how much you're giving in 24 hours. Probably you don't want to go beyond 400 milligrams of bupivacaine. But usually, from what I've seen, the rates that I've set, probably between 5 to 10 mLs of the local anesthetic that you've used, the analgesic aspect, and also putting into consideration of the patient's weight and how much you want to get in less than 24 hours. So as you're setting your infusion, you should be knowing how much you want to give within the 24 hours. You shouldn't really set beyond what you're supposed to give in the 24 hours.
All right. So the other way you can ask questions is by raising your hand. I'll choose you and then you can talk. So another question from George says, great presentation, Charles. So he's wondering whether you have done any total knee replacement exclusively under a peripheral nerve block. What is your experience at CoRSU?
Oh, thank you, George. Well, I've not done any total knee replacement under any peripheral nerve blocks. The reason being, these are elective cases, and I wouldn't love a patient to start feeling the pain in the middle of the surgery. Probably all the nerves, the various groups were not catered for, and probably here you would be able to do, that is a lumbosacral plexus. You'll be much more comfortable with that. And many times these surgeries are prolonged, and you want to be sure of the anesthetic that you've given. So I have not attempted in an elective case, a patient that has paid and is coming in for a knee replacement. But we've done ORIFs and extensive debridements of the humerus, I mean of the femur and the knee in highly septic patients. And yeah, septic patients, yes, we've done that, but not the arthroplasties.
So so you said the block you would use was the lumbosacral plexus. Lumbosacral,
you will have a unilateral blockade. I mean, you can even have a tourniquet, because usually you put a tourniquet as high as let's say mid thigh. You'll have a tourniquet there. So if you only do the lumbar plexus, the patient may start complaining of tourniquet pain, maybe 30 minutes down the road or an hour down the road, and maybe you'll be forced to combat with general anesthetic. But if you do a lumbosacral plexus block, that's the lumbar plexus and the sacral plexus, then you can have the tourniquet and you have the surgery done.
Right. So regarding the lumbar plexus, 3-in-1 block and the femoral nerve block, have you seen a modification where they do a femoral nerve block, but with the needle facing sort of cephalad? And if you have a catheter, you can, as you use hydrodissection as you advance, so that it sort of ends up performing a lumbar plexus via the femoral root.
Well, depending on the volumes that you've used, you should be able to have, because it's a fascial, it's a track. These nerves are moving in the fascial tunnels. So if you use a significant volume, you should be able to have this local anesthetic tracking upwards, but you're not sure of the spread and catering for all these branches or divisions from the lumbar sacral plexus. That is lateral femoral obturator, the femoral nerve block itself, the femoral nerve itself, and then of course the genicular branches that supply the sacroiliac hiatus and the medial part of the thigh. So you can be able to do that, but the consistency and the reliability of the block that you've done may not be sufficient, unless if there is a special indication for doing this. Let's say you want to minimize on the concentration that maybe you, I don't know. Unless if there is a special indication that you want to use it for, but I don't know.
Okay.
But I've not done any of that nature, and I think I've not come across a study.
Okay. Okay. So then about the saphenous nerve block. So when you do the femoral nerve block at the adductor canal, there is blockade to the vastus medialis. I've seen a modification where they do it more distal, like towards the distal thigh. So it becomes a fascial plane block where you deposit the drug between the sartorius and the vastus medialis to cover the saphenous nerve. I don't know whether that works. I haven't tried it, but they claim it should prevent blockade to the nerve with minimal motor block. So the other question is from Dr. Daniel Obua. He says the talk has been very informative. He's wondering what it would take for us to have a workshop for the common nerve blocks. This is for directed to Faith, Kojjo, and our sponsor, David from B. Brown. So Charles, you can start now.
Thank you, Daniel.
About the conference. Yes.
Thank you, Daniel. I think late last year, mid last year, early last year, we were planning to have this workshop, but I think we were interrupted by the pandemic. So I think they may have to make arrangements, because with B. Brown and of course AAU, and then we can have the workshop conducted, of course, with keeping into consideration of the SOPs for the prevention of the pandemic. Yeah, I think that should be fine.
Okay. Mr. David is going to follow up on that, since they are the sponsors for the regional workshop. About the Eyepatch Block, I've seen on your images that the probe is placed a bit medial, in the medial part of the thigh. Is it possible to place it directly below the knee in the popliteal crease, so that you can still visualize the needle at the full length? Then what is the risk of injecting into the vein, because it's usually quite collapsible in some patients when you do the Eyepatch?
Yes, you could place it just like the way you would do the popliteal. That is also a positioning that you could use, but you really want to see your entire needle, and most of the time you're using a low frequency probe. This when you place it medially, it gives you should I say, an opportunity to see your entire needle, to see the needle trajectory, because you're passing in between of course you have the vascular structures, but also you don't want to puncture the posterior aspect of the capsule. So you want to see your entire needle. If you happen to maybe scan, you'll be able to see that, yes, I have enough space to turn on my needle if I scan from the medial aspect, and I can be able to visualize it from a distance, as compared to putting the patient in a prone position. Although you have to put the patient in a prone position to be able to have that trajectory. And then depending on the pressure that you've used, but most of the time, I mean, By the time you're able to press that vein onto the posterior aspect of the femur, you've used a significant amount of pressure. So of course, the other maneuvers, you put Doppler and see if where the vessels are. Actually, you would be able to do the block with the Doppler on, so that you know this is where the vein is, and this is where the artery is, and I'm going in between. That should be able to guide you as you're tunneling your needle.
All right. The last one. So regarding the pink block, these ones are usually covering only the articular surfaces, but it wouldn't cover the incision site for the total hip arthroplasties. So would you supplement such a block? And is the lateral hemirectunius enough, or you would have to do also the posterior cutaneous?
Yeah, thank you so much. Yeah, that's covering the articular, almost the anteromedial and lateral aspect. That is the obturator, accessory, and then the femoral. So you're missing out on the lateral femoral cutaneous nerve. The lateral cutaneous nerve is done, usually do it differently. You go for the anterior superior iliac spine. It's say 2 centimeters medial to that, and do a little bit of a numbing of your needle, puncture the skin, and go through the first fascial layer, and you deposit about 5 ml of the local anesthetic. It passes around medial to the anterior iliac spine, and then it comes and lies on the anterior aspect of the sartorius. If you're scanning, you should be able to block it on top of the sartorius. It's easy to be visualized on top of the sartorius or in the body of the sartorius. That's okay. If you're using the ultrasound. Sometimes they make the incision too posterior that even when you do the lateral femoral cutaneous nerve, you miss out on the innervation. You have involvement of the sciatic and the sacral plexus. So I prefer sometimes doing an infiltration along the skin, because the incision is made too posterior, that it's not in the usual trajectory of the lateral femoral cutaneous nerve. So I may infiltrate on the skin, but if the incision is just on the lateral aspect of the thigh, then I can confidently do the lateral femoral cutaneous nerve of the thigh. It can be quite disturbing if you miss it out. The incisional pain can be quite painful. So if you're not sure of where they have made the incision, they can just give them some 10 ml or 0.25 and they can infiltrate. Or you can do the lateral femoral cutaneous nerve. It's a kind of a superficial block you can do.
All right, thank you. So to our sponsor, Mr. David, I hope you're still with us. For these elastomeric pumps, do they have predetermined rates of flow, 10 mils per hour, 5 mils per hour, or do you set them? And how much is the peripheral nerve block that has the nerve locating pin?
Yeah,
David, yes.
Yeah, the elastomeric pumps do have predetermined volumes and rates, both for the long term and short term. Now, the other one is basically the technology of the ultrasound has that on vision kind of software, which enables you to pinpoint the needle point. So it's not the needle itself, but it's the technology of the ultrasound itself. Have you understood me?
Yes, yes. Yeah. So there is a nerve stimulator that has a nerve locating pen. You place it on top of the skin and it stimulates from transcutaneous. Do you have that?
Yeah, yes, the pens are, yeah, we do have the pens from Big Brown. We also have had some of them in the market. I think 1 or 2 doctors have bought them historically.
Okay.
Yeah, just check with the local supplier if they still hold any stock currently.
All right, all right.
Yeah.
So thank you very much. Those were the last questions. I can't see any more questions. Everyone seems to be happy with the presentation. So thank you. Thank you to B Brown, our sponsors, for this talk. Keep supporting them. Their contacts are all over the place in case you have to buy any of their products. If you would like to have an apprenticeship with Dr. Kojjo, you can still give him a call. He's also very approachable. Do not forget, we are in a new year. We still have COVID, mask up and sanitize. Then we are also, your annual subscription is due. So let us pay up so that we can get good benefits from being members of the Association of Anaesthesiologists of Uganda. Thank you very much. Those are the final words. Any last words from Kojjo? Any take-home message?
I'd muted. Sorry. Thank you. I think the take-home message is, yeah, I mean, it's something that we need to cultivate as anesthesiologists, as in terms of our pain management. Because when you pick up this skill, trust me, your patients will be very comfortable, especially if you're doing any kind of surgery. I mean, could be general surgery or could be cardiothoracic. When you deposit the local anesthetic where it's supposed to be, trust me, for the next 24 hours, 12 hours, your patient will always remember your name. Or if they've had a surgical exposure somewhere and they went through a troublesome post-operative period, if you deposit the local anesthetic where it's supposed to be, they will never forget that moment. And of course, if you add the other modalities, patients will always be comfortable and satisfied. I think it's, yeah, let's cultivate the art, let's cultivate the desire to further kind of pick up these skills, and all aimed at improving perioperative care of our patients. Thank you so much for your time, and may God bless you.
Yes, thank you, Charles. There are a number of ultrasounds that have been procured by a number of anesthesiologists. So I think everyone, we are moving towards the right direction. You can also get the nerve block needles from B. Brown, as well as their pumps. Thank you very much. This is the end of our talk. Have a nice evening.